Hey folks, Scott Weingart here, and this is not an MCRIT podcast. This is a lecture from SMACC in Chicago. This was an amazing debate between my friends Rob MacSweeny and Paul Marik, and it was posted on the Intensive Care Network site and on the SMACC podcast feed, but there was a video done by Rob, which was hysterical, and Paul had a bunch of slides, and the SMACC folks did not put those up. They weren't synchronized. Why? Because they're really busy. They're planning SMACC Dublin. And not just that, but Ali is up on some cliff somewhere sitting outside a cave meditating, and he needs to get his mind in the right place. And Raj, he's drinking port and polishing his monocle collection. So, I understand why these guys didn't have the time to get this done. So I took it upon myself. I have really nothing better to do with my life. So I took it upon myself to synchronize the video, put up the slides, and post it as a video. Put it back up on the Intensive Care Network site, guys, because this is the way it should be seen. It's all the work Rob did should be beautifully presented in sync. So here you go. I hope you like it. And it's just fantastic. These two are characters, and I love this debate.
So our final fight will be, I think, a good one. And we are revved up. Rob MacSweeny, who unfortunately is having to do the Twitter feeding as well, but I think he's just delegated it to Myberg. That'll be interesting. So Rob is a consultant in intensive care at the Royal Victoria Hospital in Belfast, and he is in the pro for predicting fluid responsive is a waste of time. Rob, you're on.
Imogen, thanks very much. I'm going to come down here. I don't need that. Dan, can we have number one, please? So I concede I have no hope of winning a contest with Professor Marik on predicting fluid responsiveness. He's published hundreds of articles in the field and is widely regarded as a world-leading authority. His paper, Central Venous Pressure, a Systematic Review, and A Tale of Seven Mares, changed modern fluid management. Men tremble in his presence. Women swoon at his feet. I'm a no one. So instead of debating with Professor Marik, I'm going to tell you a story. I'm going to tell you a story about a guy. Imogen, give me a name.
Paul.
Perfect. I'm going to tell you a story about a guy called Paul. Now, Paul's a doctor, and he's an expert in his area. He's lectured around the world. He's famous and very important. He only works in the best place and has an office to match his standing. Paul's been working very hard recently on a major piece of work, which will be the culmination of a glittering career. Now, Paul's a big fan of Steve Jobs and likes to have similarly big announcements. So he gets on the phone, he books the local theatre, and he brings his research team down. Paul's on stage, and he starts the Steve Jobs routine, bigging up his massively important study and whipping the crowd into a frenzy. It's his plan to take the phone call from the New England Journal of Medicine live on stage so everyone in the team can share in the glory of the acceptance of the manuscript. His cell phone rings. It's Jeff. They chat for a minute or two. It's all going well until Paul starts to look worried. He can't believe it. The news isn't good. The crowd go quiet. Men and women begin to weep openly. It's just too much for some. And Jim, poor Jim, he collapses. He's rushed to hospital where Paul is ready to treat him. His blood pressure isn't looking so good, and this creates a dilemma for Paul. Does he give him fluid or not? Paul knows excessive fluid is harmful, so he only wants to give Jim fluid if he's going to improve his circulation. Paul's well read, so he knows the current theory of fluid management is to only give fluid if it's going to increase stroke volume by 10 to 15%. He also knows there are several ways of predicting fluid responsiveness. That is, determining whether a fluid bolus would likely increase stroke volume without actually giving that fluid bolus. So perfect. Paul knows if he's going to manage Jim's hypotension. His next question is, which method is he going to use? At this point, his colleague Bill comes in and says it's easy. Just check the central venous pressure. Use the 5-2-1 rule. If the CVP goes up 5 points, Paul's really grateful for the help. But it's pretty sure that a central venous pressure at any level is about as good as tossing a coin, unless your patient has 4 legs, eats grass, is bigger than a sheep, and faster than a cow. So that's out. What about the pulmonary artery catheter? Well, Paul knows equally, even in healthy individuals, the pulmonary artery catheter has no relationship with either fluid responsiveness or volemic status, so that's out. He's heard quite a bit about heart-lung interactions and the pulse contour, pulse power analyses that can be made as a result, and thinks these are the real deal. These will fix Jim. At this point, Bill comes back in and points out that virtually no one in an intensive care unit actually meets the preconditions required for the accurate use of these devices, like the absence of spontaneous respiration, the presence of sinus rhythm, and so on. But don't worry, says Bill. I brought you one of these special central venous catheters from Detroit. You can even measure the SCVO2. Anyway, says Bill, aren't you familiar with the accuracy of these semi-invasive devices? Their error limits can be up to 30%. And the non-invasive devices, they've been said to fail to meet the basic requirements for accuracy as set by the Association for the Advancement of Medical Administration, of Medical Instrumentation. 30%, just think about it. Last year, the European Space Agency sent a probe 300 million miles to a comet. If they were working with error limits of 30%, it would have landed anywhere between Uranus in our solar system and somebody else's anus, 3 galaxies away. So Paul stops and thinks, poor Jim, he's looking pretty sick. In fact, his head's about to fall off. What's he going to do? Paul remembers something about tilting and auto-transfusing with blood from the splanchnic circulation. He explains to Bill what he's trying to do as he just battle with the bed controls. Nice thought, says Bill, but all you're really doing is testing Joe's adrenergic system. It's a confounded test, but good luck with the bed controls. Our nice guys at NASA are having a bet with the guys at the European Space Agency to see who the hell can get the bed controls to do what they want it to do. Paul scratches his head and thinks, what else could he use? What about bioimpedance or bioreactance? They're loosely based to converting an electrical signal from the pulsatile chest into a useful number. He's deep in thought trying to figure out the science behind these when he realizes he can't concentrate. His focus is broken by the sound of running water. He turns to see Bill laughing so hard, he's lost consonance. One by one, various colleagues come and suggest other monitors he can use, but deep down, he knows none of them are reliable. And then he wonders why there's so many of them. And it becomes clear to him, these fluid responsiveness devices, they're all limited. They're WMD, weapons of mass distraction. Paul realizes all his efforts have been focused on the devices and not on Jim. These devices have been validated against a so-called gold standard, the pulmonary artery catheter, which itself suffers from problems with accuracy. Or worse, they've been validated against each other. The validation studies were small, single-center, often enthusiast-led, and done in the highly controlled theatre environment rather than in acutely unwell, critically ill patients. The devices all suffer from an inability to cope with changing hemodynamics. They measure surrogates rather than what we actually want them to know. And they come with so many preconditions. Paul realizes that in order to get a true measure of fluid responsiveness, he's going to need to get the sun, the moon, and the stars to align, appease the god of hemodynamics by making a sacrifice of that cow, and travel 100 million miles to ask that nice alien if he can have his monitor back out of his ass. But the infection control people in the hospital aren't going to like that, and then the usual standoff occurs. So Paul stops again and thinks and realizes he just doesn't have the ability to do what he wants to do, predict the future in a state of chaos. Neither does the European Space Agency, neither does NASA. Jim, barely conscious but still alive, wants to tell Paul that he doesn't care whether some machine inaccurately measuring a surrogate tells him his stroke volume goes up the fluid bolus or not. He just wants to live, but he can't because he's now intubated, sedated, paralyzed, and being ventilated with injurious tidal volume. He's about to be DC cardioverted so Paul can use that nice machine that he read about. It's Jim's birthday today. He was hoping for a nice iPad. Instead, he's going to be electrocuted. So Paul goes back to being a doctor and a scientist. And instead of focusing on the devices, these weapons of mass distraction, he stops and thinks about what he's doing. Guessing. He prefers assessing to guessing, so he gives a little fluid and sees what happens to stroke volume. This is, after all, the most accurate way of predicting fluid responsiveness. The only knowledge Paul needs is to use a restrictive fluid regime, use a vasopressor early, then de-resuscitate a day or two later. He knows from the anesthetic literature a simple restricted fluid regime is as good as a monitor-guided, goal-directed approach. So he gives a little fluid and a little more, and Jim gets better. Paul has saved his life. Paul had an incredible day. His life work was rejected. His friend and colleague almost died. He had a revelation regarding circulatory management. He saved his friend. He's drained. And then his phone rings. It's Derek. He has good news. JAMA would be delighted to publish his revised manuscript. The centerpiece of a new career, a stellar career, is just one question. Why the strange title?
Well, our next speaker hardly needs any introduction. So Paul Marik is Professor of Medicine and Chair in Critical Care and Pulmonary Medicine at the Eastern Virginia Medical School. So over to you, Paul.
Thanks.
10 minutes.
Yeah, thank you, Rob. That was kind of entertaining and really good, actually. It was quite funny. For a guy that comes from a place I'm not sure where he comes from. So it's really not astrophysics. And it's pretty basic, actually. And it's really important. If you resuscitate people, there's nothing more important than getting this right. So he got it kind of half right, but also kind of wrong. So I need a clicker thing. I forgot. I got to move forward, not backwards. So my talk was 300 slides. I randomly removed like 270. So I'm not sure what was left. So, like many of the other speakers, history actually is quite informative. So this was published in The Lancet in 1832. I think my colleague was kind of read this at that time. So this is a picture, this is in Sutherland, a sketch of a young woman in her 20s who was dying from cholera from hypovolemic shock. And you can see she doesn't look too hot. And if you remember at that time, the treatment of the day was venesection. So this was someone who was in hypovolemic shock, and I think it was endorsed by the Surviving Campaign, is that we actually venesect patients, we remove all the bad stuff, and that makes them better. So in fact, there was this guy, Dr. Ladder, who thought this was stupid. So you actually have to sometimes go against mainstream thinking. And he actually was the first person in recorded history on this planet and any other planet to actually give a patient intravenous fluid. And it's very informative to actually read what he did. So this was an excerpt of what he did. So his first patient was an elderly woman who had reached the last moments of her earthly existence. Having no precedent to guide me, I proceeded with much caution. Ladder inserted a tube into the basilic vein and injected ounce after ounce of fluid, closely observing the patient. And that is such an important observation, it's possibly repeating again. Ounce after ounce of fluid, closely observing the patient. The sunken eyes and fallen jaw, pale and cold extremities, bearing the manifest imprint of death's signet, began to glow with returning animation. The pulse returned to the wrist. This is the first description of volume resuscitation in a dying human being. And from this humble beginning, we've gone to this. This is called the Rivers Protocol, in which you give large volumes of resuscitation, fluid. And I'll just pick one study. This is from the Mayo Clinic. I'm sure you've heard of the Mayo Clinic, one of the more prestigious institutions where the best intensivists work in the world. This is recently published. They looked at 400 patients with severe sepsis and septic shock who were resuscitated with early goal-directed therapy. At 24 hours, 67% of patients had clinical evidence of volume overload. At 72 hours, half the patients were volume overloaded. And volume overload was an independent predictor of death. And so death's not a good thing. Your mortality was increased twofold if you were volume overloaded. So early goal-directed therapy should be termed iatrogenic saltwater drowning rather than resuscitation. Unfortunately, our patients get volumes of normal saline and they drown in this fluid. So as my colleague says, this is my friend, give them as much as they need and not a single drop more. The real question then is, how do you know when you've reached the limit and you give no more? So people use physical examination. This is a really interesting study. You can see the pylon in the middle of the road going nowhere. So they looked at physical examination, CVP, chest X-ray, as predictors of volume status and volume responsiveness, and they were all useless. All were useless, and multiple studies repeat the same findings. So really you have to ask yourself, well, what's the question? Most people ask the wrong questions which read down the wrong pathway. What is preload? I'm not sure what that is. What's the CVP or wedge? As we know, it's particularly useless. Is the tank full? So most of my patients don't have tanks, they don't have gas gauges, and they don't have things that I can assess their tank. So I'm not sure where this tank is. What's the cardiac output? It's kind of meaningless. My friend here doesn't have a cardiac output, yet he seems to be surviving. So cardiac output in itself doesn't help you. Stroke volume, pulse pressure variation is useless in the ICU. Maybe it works if you're paralyzed on a ventilator, have 8 mils per kilo in the operating room. In the ICU, it's a complete and utter waste of time. And it seems to be that we have this collapsing problem. So this thing is caught on, does the vena cava collapse? And we run around looking at the collapsing vena cava, and somehow this predicts something. Actually, it predicts nothing. And a recent paper, and I didn't even know there was such a journal, the Australian Journal of Emergency Medicine, they actually used such a journal, they looked at this, they found the ROC was 0.46. So actually, flipping a coin is actually more predictive of fluid responsiveness than looking at your IVC. So really, there's only one right question, is my patient fluid responsive? Where is he on his Frank-Starling or Homer-Simpson curve? Because that's really important, because that tells you what he's going to do. And really, the only reason to give fluid, there's no any other reason, you don't want to fill the tank, is to increase stroke volume. If you're not increasing stroke volume, what's the point? And one of the most fascinating observations, and it doesn't really matter what study you look at what continent you look at, and what setting you look at, if this is in the operating room, the ICU, the emergency room, the floor, only half of patients who are hemodynamically unstable respond to fluids. It's an absolute fundamental concept. And the idea that fluids are the cornerstone of resuscitation is obviously bull, because half of patients do not respond to fluids time and time again. And we talk about fluid responsiveness as an increase in stroke volume. You have to be biventricular preload responsive. So if your RV is failing, fluid's not going to help. So we spoke a lot about sepsis. This is a really interesting study done in 1988. Probably my colleague wasn't born yet. So they basically looked at fluid responsiveness in patients with sepsis. We can see what happens in healthy people. You give fluid, it increases EDV, end-diastolic volume, increases preload, increase actin-myosin overlap, you increase stroke volume. You give it to people in septic shock, what happens? EDV doesn't go up, stroke volume doesn't go up. It actually doesn't do anything except increase your left ventricular end-diastolic pressure, cause pulmonary edema. People with sepsis and septic shock are not fluid responsive. We know this now 25 years ago, and the reason why sepsis causes diastolic dysfunction, high volume resuscitation causes diastolic dysfunction. All you're doing is shifting fluid from the bag to the tissues without any hemodynamic improvement. And the idea of giving large fluid boluses, 20 to 30 moles per kilo, violates the basic principle of medicine. First, do no harm. It leads to severe volume overload with increased complications and death. So there's actually quite interesting. There were these two drunkards, Frank and Starling. They met in a bar. They came up with this Frank-Starling curve. And then there's these two dumbwits, Marik and Phillips, and we'll only be famous when we're dead like these other two guys. So you put these two curves together, it's really quite fascinating. So the Marik-Phillips curve is the black lung water curve. The Frank-Starling is the preload curve. So it's a very interesting physiological observation. If you bottom of the curve, you give fluids, you increase stroke volume. You do this with a tiny increase in lung water. Large increase in cardiac output, small increase in lung water. Most importantly, your filling pressures do not go up significantly. The gradient between your mean circulating filling pressure and CVP goes up. You increase venous return. When you're at the top of the curve, you get a tiny increase in stroke volume, a massive increase in lung water, and a large increase in filling pressures. So what this means is as you climb the curve, you get diminishing returns. So you really need to know where your patient is on his or her Frank-Starling curve. That's really what you need to know. So the question is, well, how do you assess that? So we can use ROC curves because they're probably the best way of looking at accuracy. If a test is worthless, ROC of about 0.5. If it's fair, it's about 0.7. If it's excellent, about 0.8 to 9. And really, if you're looking after patients, you don't want to be wrong half the time. You don't want to be wrong 30% of the time. You want to be right most of the time. So it would seem pretty dumb to choose a worthless test, but it seems the world is bent on using worthless tests. So we go through those tests that are useless, the CVP, the IVC, flow time, even look at ventricular diameters. IVC, SVC variability should actually be useless because it's useless. Pulse pressure variation, stroke volume variation, it's right about in the best of circumstances. So in the operating room, when you're anesthetized on 8 moles per kilo and you're paralyzed, it's about 0.7. So there are only two techniques which really predict fluid responsiveness with any accuracy. Lifting the legs, somewhat impolite, but it actually works really well and is brilliant, or just give a fluid challenge. And there are a whole bunch of technologies that you can couple these with. We've got to talk about the CVP because it just won't go away. It just will not go away. Oh, I have to stop. Okay. Area under the curve, 0.56. The new Surviving Sepsis campaign, which is now actually the law in the United States of October the 1st, you either examine a patient, we know that's useful, or you measure the CVP mixed venous bedside ultrasound. This is an interesting study. I'll be 2 seconds. So this is looking at mortality and sepsis, Rivers trial, the Janssen lactate trial, Prowess, Process, and Promise. You can see mortality came down, slightly lower with a rise. The Apache was lower. You can see how fluids in 72 hours came down. Interesting, if you plot CVP, the goal CVP, versus the amount of fluids, you have an R-squared of 0.84. So this means that people are targeting the CVP. The higher the CVP, the more fluid you give. So there's got to be an easier way, the PLR or volume challenge. The PLR is pretty simple. You lift their legs. It tells you within 2 or 3 minutes where they are on their Frank-Starling curve. It's like a fluid challenge, no fluid. And the ROC on this study was 0.95. We've done a meta-analysis of 24 studies, shows an ROC of 0.96, which is better than any other technique available. So if the patient's fluid responsive, you may do nothing. If you're going to give fluid, you give a little bolus, or you may want to give an alpha agonist. The most important part of this is do something and see what happens. Don't just walk away like a goof. See what happens, assess what happens, and this is the most important part of hemodynamic assessment. So that's a brain, which is lightened up. And you need one of those at the bedside because you can't do this with protocols or checklists. You need someone at the bedside whose brain is working and is thinking, and then you have this other information feeding in. Thank you.
So Rob is now allowed 4 minutes.
Cheers. I just need the 2.5. Dan, can we have number 2, please? So Paul's paper, Predicting Fluid Responsiveness, a systematic review in a tale of 5 aliens, has not just been a global hit, it's been a universal hit. And those nice aliens from the planet Zog are so impressed, they issued their first invite to a human to speak at their World Congress of Critical Care. So Paul talks to the guys from NASA, and they fix him up with a spacesuit and a spaceship and a mission control, and off he goes. But it's a long, long way from Earth to Zog, and he gets lost, and then he runs into the wrong solar system. But eventually, he arrives to his customary ecstatic welcome. And he thinks this is going to be a nice intergalactic jolly. But these Zagonians, they're big fans of the human critical care literature, and they're asking some hard questions. Like Starling curves, have they ever been validated in humans? And it's normal to be fluid responsive. Why target a pathological state of non-fluid responsiveness? Why aren't you measuring organ perfusion, or better still, tissue oxygenation? How does fluid responsiveness account for vasopressor dose? Is it volume overload is the problem, or sodium overload? Can these fluid responsiveness devices differentiate between hypovolemia or venodilation? Wow, Paul wasn't expecting this. There are just so many holes in the fluid responsiveness paradigm. And then Bill appears. To show him a paper from last year stating, ultimately, only 2 techniques are currently available that can be used to determine fluid responses with a high degree of accuracy, namely the passive leg raising maneuver and the fluid challenge. Paul knows a fluid challenge is an assessment of responsiveness, not a predictor of it, which just leaves the passive leg raising test. The whole way to Zog, none of the astronauts could get their beds to work. That just leaves the passive leg raising test, and that's a crap test. That leaves Paul with just one conclusion. Then he recognized the similarities between what's happening now and what's happened with sepsis therapy over the past 15 years. A biomarker-guided resuscitation was initially heralded as a huge breakthrough, only to be subsequently overwhelmingly shown to be no better than usual care. The message from that saga was it was the delivery of early appropriate therapy that was appropriate. That was important, not the trigger to deliver the early appropriate therapy. There is an easier way. Just aim for restricted fluid management using vasopressors and de-resuscitate early. The volume required for fluid resuscitation may itself just be a biomarker of illness severity. Weapons of mass distraction are unnecessary. Paul stops and he explains his new enlightened state to the Zagonians to rapturous applause. And then he picks up the intergalactic phone. Not to Jeff. Derek's his new favorite. He's not done with the biggest paper of his career just yet. Part 2 is just starting, and he knows exactly what he's going to call it. Thanks very much.
Well, let's see if Professor Meyerberg's found the Twitter account. You should be.
Hello?
Yep.
Okay. A lot of comments, bouquets to both. Certainly bouquets to Chris for the caliber of his presentation. Some saying it's the best presentation of the whole conference, which is a big call. And lots of bouquets to Paul for his dissertations on the uselessness of things.
And his on and on and on and on and
That
on.
wasn't tweeted.
Oh, it wasn't tweeted.
But you were tweeting away about that. I guess a couple of questions from Twitter. The one thing was that Paul Marik should refer to CVP measurement in sepsis as hashtag sepsis wankers. I guess it's the place for new hashtags. Anthony Holly. Right, a question. A question here is addressed to you, Chris. The question was, what about changes in end-tidal CO2 with passive leg raising as a marker for fluid responsiveness?
Yeah, interesting. I'm not sure it's been researched to any huge degree. Paul will be a much greater expert on that than me. I think one of the problems with the passive leg raising test is unless you're measuring the stroke volume, the return of blood back to the right ventricle or back to the right atrium, then the risk is you've just given an adrenergic stress test, and simply saying that the heart rate hasn't increased and that's therefore not an adrenergic response isn't really good enough. So that's the problem I have with the passive leg raising test, that we don't actually incorporate that aspect into it. But as regards the end-tidal CO2, but I'm not aware of any large studies. It'll be a small physiological study, so maybe Paul would be more familiar.
Well, I'll just, that question came from Ryan Klauser, just to clarify. The question, sorry, for Paul to rebut, is from Nick Mulcahy. Dr. Marik, what is the best way to evaluate plus or minus passive leg raise? So how do you do a passive leg raise?
So in terms of the first question, end-tidal CO2, it's an interesting one because we know when you resuscitate people and you restore cardiac output, end-tidal goes up. So there have been a few studies looking at fluid responsiveness and end-tidal CO2. You have to be intubated, and the change in CO2 is pretty small, so the fidelity is small. And if you have underlying lung disease, COPD, you get VQ mismatching, so it makes the prediction, it's less predictive. It's something you can look at, but it doesn't have the same degree of accuracy, but people have looked at it. So in terms of what technique to use, you have to use any technique that can measure stroke volume beat to beat, real time. And obviously there are a whole bunch of different techniques, calibrated pulse contour, bioreactance. You can do carotid Doppler has been shown to be quite good, so you look at changes in carotid blood flow is pretty accurate. So there are a number of techniques. It doesn't really matter which one you use, but it has to be real-time, beat-to-beat change in stroke volume. I suppose in places that are resource limited, learning how to look at carotid Doppler is easy. Most people have carotids, and when you actually, people in shock redistribute from their arms to their head, so that when you actually give fluids, the increase in blood flow to the brain exceeds the increase in stroke volume. So an increase in carotid Doppler flow velocity is a good indicator of fluid responsiveness. It can be done in the bedside at the ER, and you don't need any fancy technology.
So Rob, I might ask you a question. At the bedside, are there any techniques that you would use to predict fluid responsiveness?
So I think it's like one of the main points coming out of yesterday's sepsis smackdown was be a clinician. Take as much information as you can and stop looking at one or two things. Take everything in its totality. So the history, the examination, the investigations you have, it all goes in together. So as we heard yesterday, most patients with, for instance, sepsis, they don't have Ebola or cholera. They haven't lost liters of fluid. So therefore, they don't need liters of fluid. So once you're giving liters of fluid, you're probably doing something wrong. So I think having ballpark figures for the pathology that you're dealing with is very, very useful. And if you're going to use an investigation, a lot of us, I think, have moved towards transthoracic echo, although, again, it hasn't really been validated for that use. A lot of the monitors just aren't as accurate as we think they are. People act on them, and I think that's problematic. I think people need to realize that these monitors are not as accurate as they think they are.
So Paul, a question to you. In the middle of the night and you're not there, and your juniors are treating someone, how would you encourage them to predict fluid responsiveness, given that they have not got as much clinical experience as you have?
Yeah, so we may be an aberration. Our nurses have been trained to do PLRs. They do it on their own. We measure blood pressure, we measure pulse, because we think that's important. And our nurses do PLRs on their own independently. They know what it means. When I started in this hospital, people spoke about CVP. It's not acceptable. You get thrown into jail. They now talk about fluid responsiveness. The nurse will call you and say, Mr. Jones's BP is low. He was fluid responsive. What should I do? So the nurses drive it. Our residents are stupid. They don't understand what to do. So
So, because my next question is, how do your juniors become experienced specialists?
yeah, so they see what the nurses do, they see what we do. So the first thing we tell them is never argue with an ICU nurse. She knows best, and you don't want to piss her off because she'll make your life miserable. And you know,
True.
if you empower your nurses to do stuff and they take it on, they will do a remarkable job. And that's what our nurses do. It's the most remarkable thing, because at 2 a.m, I don't want to come and evaluate every patient. They can do a PLR. When we started doing it, we did PLRs on all of them. We got them on the ground, and we lifted their legs, and we did all things. And
So you go to jail, you lie on the floor. It sounds a great place.
yeah, and it's fun actually, because it's all based on physiology. If you understand the physiology, it speaks for itself.
Okay, I'm aware of time. So, audience, are you going to agree with Rob in predicting fluid responsiveness is a waste of time? Oh, Rob. Ooh, a little bit more. And those who would support Paul's argument? Paul, you win. Well done.